Welcome to the Deep Dive. Today we've gathered a whole stack of sources. We're talking articles, global health reports, the latest clinical trial data, and we are zeroing in on a condition that really tells two different stories.
It absolutely does. We're talking about valvular heart disease, VHD, and more specifically, aortic stenosis, or AS.
Right, and when you think about major public health threats, things like stroke or diabetes, VHD might not be the first thing that comes to mind.
But it's a massive cause of sickness and premature death all over the world. So our mission today is to really unpack that dual nature.
Dual nature.
Yeah, the burden it creates in low-income versus high-income countries, the surprisingly aggressive biology behind it, and then the revolutionary treatments that have these really high-stakes trade-offs.
And that split is it's genuinely shocking. It's like two completely different diseases happening at the same time on the same planet.
It is.
So let's start with that. In high-income countries, aortic stenosis is really a disease of getting older, of, wear and tear.
Exactly. It's degeneration. The numbers show that. Severe AS affects about 3.5% of people over the age of 75. It's what happens when parts wear out.
But if you shift your focus, look at the global picture, it's a totally different story.
Totally different. In lower income countries, the main cause of VHD is still rheumatic heart disease, RHD, which comes from untreated strep throat.
And the scale is just staggering. We're looking at an estimated 45 to 50 million people worldwide living with RHD.
And it's concentrated, mostly across sub-Saharan Africa, South Asia, and Oceania.
Okay, let's dig into RHD for a minute because the variation geographically is just extreme.
It is. The sources cite some incredible differences. You can go from a rate of, say, 1 per 100,000 kids in a place like Costa Rica.
1 per 100,000.
To 150 per 100,000 in parts of China. That's a 150-fold difference.
And it's not just that more people get it, right?
Yeah.
The disease itself acts differently.
It progresses much, much faster.
Mm-hmm.
In these economically deprived tropical areas, RHD causes severe symptoms, irreversible valve damage in patients who are under 20 years old.
Under 20. Wow, why so fast?
It seems to be linked to repeated infections, maybe with more virulent strains of strep. So their immune systems are just under this constant attack, and it leads to faster and faster valve destruction.
So a patient in, say, Boston might get AS in their 80s from simple wear and tear.
Right.
But a patient in rural Africa might need a major heart valve surgery before they can even vote.
It's a stark contrast. And even with global efforts, the problem is, well, it's complicated. We've seen a nearly 50% drop in age-standardized mortality from RHD between 1990 and 2022.
Which sounds like a huge success.
It is a success, but it's also created a kind of secondary crisis. People are surviving the acute illness, which is great.
But then what?
But then they're left to deal with this severe lifelong valve damage. So the number of people with heart failure because of RHD actually went up by almost 90% in that same period.
So we're essentially replacing acute death with chronic debilitating heart failure.
Exactly.
Let's pivot now to the disease that dominates in high-income nations. Aortic stenosis. It's the most common valve problem in adults.
That's right. And if you have symptomatic AS, the odds are slightly stacked toward you being male.
And it's usually from this degenerative calcification process.
And to understand AS, we have to look at the root causes, which our sources break down into 4 main categories.
So what are those buckets?
First, congenital causes, like a bicuspid valve.
Oh.
Second, degenerative calcific disease, the age-related kind. Third, rheumatic fever, though it's rarer here. And fourth, less commonly, damage from radiation exposure, say from old cancer treatments.
Let's focus intensely on that degenerative calcific disease. This is where the conventional wisdom really gets challenged. We thought of it as passive, like rust on a pipe.
And we have to just throw that idea out. The sources insist it is an active disease. We need to underline that word.
Active.
It is not passive decay. The current understanding is that calcific AS shares remarkable similarities with vascular atherosclerosis, the disease that causes plaque in your coronary arteries.
So it's the same underlying mechanism, just damaging 2 different structures. That's a critical realization. So what's the sequence of events here? How does a healthy valve turn into a rigid, calcified mass?
It starts with injury and inflammation, specifically endothelial dysfunction damage to the inner lining of the valve, maybe from chronic mechanical stress or high blood pressure.
And that damage lets lipids get in.
Yeah.
LDL cholesterol, LPA.
Exactly. And the body sees this as an injury site, so it triggers an inflammatory response. Macrophages, T lymphocytes, they all rush in, releasing cytokines. It looks just like the early stages of plaque in an artery.
And then comes the really shocking part. The transformation into bone.
Yes, this is the critical step. The persistent inflammation fuels this fibrocalcific response. And specialized valve cells called valvular myofibroblasts, they differentiate, they change
Into what?
into osteoblasts.
Bone-forming cells. That is a direct biological switch. In the heart valve.
Exactly. These new osteoblasts start actively producing bone matrix proteins. This leads to the deposition of calcium hydroxyapatite crystals. The valve is literally calcifying and ossifying itself. It's forming bone where it shouldn't be.
Given that direct link to atherosclerosis, it just makes perfect sense that the risk factors are the same.
They're nearly identical. Hypertension, high LDL, diabetes, smoking, chronic kidney disease. All the usual suspects for heart disease are also strongly associated with the progression of AS.
How strong is that link?
Well, one big Canadian study cited in our sources found that these common risk factors accounted for about a third of the population attributable risk for severe AS.
We should also briefly mention the precursor condition, aortic valve sclerosis.
Right. Sclerosis is just some focal thickening and calcification that doesn't cause a major blockage yet, but it affects about 30% of people over 65.
Which is a huge number.
And it's not benign. Sclerosis is a predictor. It's associated with an excess risk of cardiovascular death and heart attack. It's the early warning sign that this active calcification process has begun.
Okay, let's switch gears to the most common congenital cause, the bicuspid aortic valve, or BAV.
BAV is the most common congenital heart valve defect. It affects maybe 0.5 to 1.4% of the population, with a strong male predominance, maybe 2 to 1, even 4 to 1.
And it's just what it sounds like, 2 leaflets instead of the normal 3.
Exactly. And because those 2 leaflets bear all the mechanical stress, patients with BAV tend to develop symptomatic AS 1 to 2 decades sooner than people with the degenerative kind.
It just accelerates the whole timeline. And BAV often goes hand in hand with a problem in the aorta itself, the aortopathy.
That's a critical association. About 30 to 40% of BAV patients have an associated aortopathy, usually an ascending aortic aneurysm.
And the most important point here is that this develops independently of how bad the valve is.
Absolutely. The aorta can be getting bigger even if the valve stenosis is mild. It's a problem with the underlying connective tissue, and that risk of aneurysm or dissection demands its own monitoring.
And it often pushes the decision toward open surgery, right?
Yeah.
To fix both at the same time.
It does. If that aorta gets bigger than 5.5 centimeters, you're almost certainly looking at a combined surgical repair.
So we've established that AS is this progressive disease that obstructs blood flow from the left ventricle, the LV. Let's talk about the consequences of that, starting with the heart's initial powerful adaptation.
The LV is a remarkable machine, and because AS usually develops slowly over decades, the LV has time to adapt. Its main response is concentric hypertrophy.
It thickens its muscle walls inward, making the chamber smaller, but the walls much, much stronger. Why is that helpful at first?
It's a genius mechanical solution, and it's all explained by the Laplace principle. Basically, the wall stress, the force the muscle fibers feel, is proportional to the pressure inside the chamber times the radius, divided by the wall thickness.
Okay, so if the pressure is rising because the valve is blocked, the stress on the muscle should be soaring.
It should be, which would lead to failure. But by massively increasing the wall thickness, the LV normalizes that stress. It keeps the force on the muscle fibers in a safe range.
So the thickening is protecting the muscle.
Exactly. It allows a huge pressure gradient to exist across that valve for years without the heart failing, and it can maintain a normal cardiac output.
Which is why we define severe AS by those objective numbers. A mean pressure gradient over 40 milliliter HG, or a valve area less than 1 square centimeter.
Right. Less than a third of its normal opening. But, like all chronic diseases, there's a point where this adaptation becomes maladaptation. The heart starts to suffer.
And what happens when that hypertrophy becomes excessive?
The LV muscle becomes overly stiff. We call this diastolic dysfunction. The heart has trouble relaxing and filling, so the pressure inside the ventricle shoots up at the end of filling.
And this happens even before the ejection fraction, the pumping function, starts to drop.
That's the key. It happens early. And that high pressure backs up into the lungs. That's where symptoms start.
And late in the disease, the pumping function itself finally starts to fail.
It does. The LV can't sustain the force, cardiac output declines, and here's the kicker. The pressure gradient across the valve also starts to decline.
Because the heart's just too weak to generate the pressure.
Exactly. And that leads us to this really challenging diagnostic category of low-flow, low-gradient AS. This patient is extremely sick, but the stenosis numbers are confusingly low.
And the heart muscle is also suffering from ischemia, a lack of oxygen.
A major issue. Even without any coronary artery disease, the thick muscle just requires more oxygen. At the same time, the supply is being choked off by the high pressures inside the heart. It's a terrible supply-demand mismatch.
So if a patient is compensating, what's a common trigger for a sudden rapid deterioration?
The loss of the atrial contraction. That stiff LV relies heavily on that final atrial kick to fill properly. If the patient develops atrial fibrillation or AFib, they lose that kick.
And cardiac output just plummets.
It can be catastrophic overnight.
Okay, moving to symptoms. The sources are clear. They don't really appear until the valve area is down to about 1 centimeter odds. But once they do, it signals that compensation has failed. What are the big three?
The big three are exertional dyspnea, which is shortness of breath.
From that fluid backup in the lungs.
Right. Then angina pectoris, or chest pain, from that oxygen supply-demand imbalance. And finally, syncope, or fainting.
And the syncope is because the heart just has a fixed output. It can't increase blood flow when you exercise, so your blood pressure drops.
That's the main mechanism. And then natural history data from before surgery was common is just sobering.
What was the prognosis?
The time from symptom onset to death was strikingly short. If you showed up with angina or syncope, average survival was about 3 years. Dyspnea, 2 years. Heart failure, maybe 1.5 to 2 years.
It's why intervention is absolutely mandatory when symptoms appear. It's life-saving. What about sudden death, though? Is it a big risk in asymptomatic patients?
It did happen in 10 to 20% of patients who died with AS. But, and this is important, most of those sudden deaths were in patients who were already symptomatic.
So sudden death as the first sign in an asymptomatic adult is pretty rare.
Very uncommon, about 1% per year, which is why we can safely do close surveillance on asymptomatic patients.
But surveillance doesn't mean it's not getting worse.
Oh no, it's relentlessly progressive. The valve area shrinks by about 0.1 centimeter meters every year, on average. It's a slow, steady march to failure.
So given that prognosis, accurate diagnosis is the first crucial step. Let's start with the physical exam. What are the classic findings?
The most classic finding is in the carotid pulse. We look for pulsus parvus et tordus.
Small and late.
Exactly. The pulse rises slowly to a delayed, weak peak. It reflects that slow ejection of blood.
But the sources caution we can't always rely on that, especially in the elderly.
That's right. Arterial stiffening from aging can mask the late part of that sign, making it unreliable.
Okay, so then we move to the centerpiece, the murmur itself. What does it sound like?
It's a classic ejection systolic murmur. Low-pitched, rough, raspy. It's loudest at the base of the heart, the second right intercostal space, and it transmits up into the carotid arteries.
And you mentioned the Gallivarden effect, this kind of acoustic trick.
Yeah, it's where the murmur transmits downward to the apex of the heart, and it can sound softer, more musical. A less experienced clinician might mistake it for mitral regurgitation.
Now, a critical point you made earlier. We can't equate the loudness of the murmur with the severity.
It's a potentially dangerous mistake. Yes, severe AS with good heart function is usually a loud murmur, but if the patient has severe AS and their heart is failing, the cardiac output is low.
So there's not enough blood flow to make a loud noise.
Precisely. A soft murmur in a sick, symptomatic patient is not reassuring. It's terrifying. It likely means the problem is catastrophic.
So we move from the physical exam to the unquestioned gold standard, echocardiography.
Echo is fundamental. It gives us everything. We can see the thick calcified leaflets, see how poorly they open. We can measure the LV hypertrophy.
And the Doppler measurements give us the crucial staging metrics.
Yes, that's how we define mild, moderate, and severe AS based on the valve area and the pressure gradient.
Now, our sources highlight the growing use of strain imaging. If we already measure ejection fraction, or EF, why do we need strain?
Strain is just a much more sensitive, earlier indicator of damage. EF measures the total volume pumped. Strain measures the subtle efficiency of the muscle fibers themselves. It can detect subclinical damage before the EF starts to decline.
So it's an early warning sign that the muscle is beginning to fail, even when the EF still looks normal.
Exactly. And the goal is to intervene before that damage becomes irreversible.
Let's go back to that low-flow, low-gradient AS challenge. If the echo is ambiguous, how do we figure out if the valve is truly the problem?
That's where dobutamine stress echocardiography comes in. Dobutamine is a drug that gently boosts heart function. If the valve area is truly fixed and small, that increased flow will cause the pressure gradient to shoot up, confirming severe AS.
And if it doesn't?
That suggests the primary problem is profound muscle failure, not the valve, pseudostenosis, which changes the whole treatment strategy.
And if the echo is still inconclusive, we turn to advanced imaging, like CT scans.
Right. CT gives us a quantitative analysis of aortic valve calcium. It's a powerful tool to resolve uncertainty in those low-flow, low-gradient cases. We can measure the volume of calcium deposited.
And the sources highlight a critical difference in scoring between men and women.
Yes, this is so important. The calcium scores that define severe AS are different. Men tend to accumulate more raw calcium. Women can have less calcium but more fibrosis, so they can have severe AS at a lower calcium score. Using one threshold for both would underdiagnose severe AS in women.
And CT has also become mandatory for planning the modern treatment approach.
Oh, absolutely. It's the imaging method of choice for planning TVI. It gives you the 3D anatomy you need to measure the annulus, size the new valve, and plan the safest access route.
Okay, let's move to the action phase. Treatment. Before intervention, what role does medical management play?
It's supportive, but it has major limitations. The sources are definitive. No currently available medical therapy, not statins, not ACE inhibitors, can slow the progression of AS.
So if a patient is on a statin, it's for their general heart risk, not to fix the valve.
Exactly. It's for their ASCVD risk. The most important part of medical management is a key restriction.
Which is?
Any patient with severe AS, even if they feel fine, must strictly avoid strenuous physical activity and competitive sports. The risk of syncope or sudden death is just too high. A lot of patients with AS also have, say, high blood pressure or coronary artery disease. The sources say that things like beta blockers or ACE inhibitors are generally safe, but with a big asterisk.
A very big asterisk. They're safe as long as the left ventricular systolic function is still preserved. That's the key.
And why is that the tipping point?
Well, if you think about it, patients with AS have two resistance circuits they're fighting against, one after the other.
Yeah.
You've got the stiff valve itself, and then you have the resistance of all the arteries in the body, your blood pressure.
So it's double whammy.
Exactly. And that's why controlling blood pressure is so critical. You want to lower the second resistance to make it easier for the heart, but it's a delicate balance. You can't drop the pressure so much that you don't have enough force to push blood through the brain and everything else. It's a real tightrope walk.
Last quick rule on medical management. Endocarditis prevention. It seems pretty straightforward.
It is. It's only for patients who've had endocarditis before. It's not a blanket recommendation for everyone with AS, which definitely simplifies things.
Okay, so now let's get into the real engine room of all this, the staging system.
Yeah.
This is the AAA-ACC model, and it's how a patient goes from just being at risk to needing a new valve.
This is where it all comes together.
And here's where it gets really interesting, because the specific definitions, they matter immensely. This whole A to D journey is about pinpointing the exact moment the heart just can't cope anymore.
So let's just walk through it. Stages A and B are the early ones. Stage A is just. You have risk factors, high blood pressure, maybe high cholesterol. The valve itself is still okay.
Just a warning sign.
Warning sign. Then in stage B, the disease actually starts. The valve is changing, it's getting a bit stiff, but it's mild to moderate. And this is key. The patient is still asymptomatic. They feel fine.
And for both of those, it's just watch and wait.
It's vigilant monitoring, regular checkups, echoes. You're tracking the progression very, very closely.
Okay, now the first big danger zone, stage C. This is where the disease is severe, but the patient still feels fine. They're asymptomatic.
Well, this is where we have to get even more granular. There's C1 and C2.
So C1 is severe disease, asymptomatic, but the ventricle is compensated. The heart muscle is thicker. It's working harder, but it's managing.
It's coping. But then you have C2, and that's the silent alarm.
What's happening in C2?
The patient is still asymptomatic. The disease is still severe, but the ventricle is now decompensating. The heart muscle is starting to fail. You can see it on an echo, even if the person themselves hasn't noticed they're getting tired walking up the stairs yet.
Wow. So that distinction C1 versus C2 is a huge red flag.
It's a massive flag. A C2 patient is on a much more urgent timeline for intervention.
Which brings us to the final stage, stage D. This is severe and symptomatic. This is when the alarm bells are ringing out loud.
This is the classic, no-brainer threshold for intervention. But even here, we have to look closer. The sources break it down into three subtypes.
Okay.
You have D1, which is the most straightforward. The patient has symptoms, severe AS, and a high gradient across the valve, over 40 millimeters of mercury. This is your classic high-pressure situation.
Then you get the more confusing ones, the low-flow types.
Exactly. So stage D2 is symptomatic, severe but with low flow and a low gradient. And the key part, they have a low left ventricular ejection fraction, or LVEF.
So the heart muscle is weak, it's already
The
failing.
muscle itself is failing. It can't even generate enough force to create that high-pressure gradient.
And what's D3?
D3 is a paradox. It's also symptomatic, severe, low flow, low gradient. But the LVEF is preserved. The ejection fraction is normal.
How's that work?
It's called paradoxical, low flow, low gradient severe AS. The heart muscle isn't weak like in D2. It's just struggling against such an extreme resistance that it can't generate a lot of flow.
Yeah.
Knowing if the muscle is weak or just struggling it's vital for planning the surgery.
So once a patient hits stage D with symptoms and severe disease, the conversation flips completely. It's no longer if, it's when and how.
Immediately. The primary intervention is what's called a Class I recommendation. That means you do it, period.
And what's the trigger?
Any patient with symptomatic severe AS that usually includes a jet velocity across the valve of 4 meters per second or more should be referred for aortic valve replacement, or AVR.
And for AVR, the big options are SAVR, surgical aortic valve replacement, the open heartway, and the less invasive one, TBI.
Exactly. And speaking of that less invasive option, it's a small thing, but it helps when you're reading the notes or talking to clinicians.
Okay.
You see the letters, TAVI, for transcatheter aortic valve implantation. But in practice, everyone in the field pronounces it as one word, TAVI.
Okay. Not TAVI, but TAVI.
TAVI.
Yeah.
It's just the standard. And it is a key option now for AVR, especially for patients who might be higher risk for the big open heart surgery.
Got it. So SAVR or TAVI. But what about those asymptomatic patients back in stage C? Is there ever a time when you'd intervene before symptoms show up?
Yes. There are two very clear lines in the sand where an asymptomatic patient with severe AS goes straight to intervention.
Okay, what's the first one?
The first is the most important physiological sign. Their left ventricular ejection fraction drops below 50%.
So the pump is starting to fail.
That's the hard line. A drop below 50% means the ventricle is failing to cope. At that point, waiting is just too risky. The damage to the heart muscle is picking up speed.
And the second reason?
It's more of a practical one. If the patient needs other cardiac surgery anyway, like say for bypass grafts or an aneurysm repair, you do the valve at the same time. You don't put them through two massive surgeries.
That makes sense. Okay, so beyond those absolute must-do indications, the sources get into some of the nuances, the class 2 recommendations. This is the reasonable to do stuff.
Right. And some of the pre-procedure workups. For example, before surgery, coronary angiography should be done pretty routinely, depending on the patient's age and risk factors. You need to know if you're dealing with blocked arteries, too.
Exactly.
So what pushes a patient into that class I territory for surgery if they don't meet the strict class I rules yet?
It's really about finding early signs that things are about to go bad, even before the classic symptoms hit.
Okay, like what?
Well, the first is an exercise treadmill test, an ETT.
Right.
If a patient gets on the treadmill and their blood pressure drops, or they develop symptoms right away, that suggests their heart has no reserve left. Intervention becomes very reasonable.
Another sign is just an extreme reading on the echo, right?
Yes, a very, very high jet velocity. We said 4 meters per second is the threshold for severe. But if you see a velocity over 5 meters per second, that's such a tight valve that the risk of a sudden event is just too high to wait.
And the last one is a blood test.
It is an elevated B-type natriuretic peptide, or BNP.
What does that tell you? High BNP is a really strong sign of increased strain on the heart muscle. All of these things, the exercise test, the super high velocity, the BNP, they're all early warning signs. They tell you that even though the patient might not be in stage D yet, they're hitting there fast, and it might be better to act proactively.
Finally, that meant open heart surgery or SAVR, surgical aortic valve replacement.
And that's still the gold standard for some patients, right?
Absolutely. Especially for younger, lower-risk patients. It has excellent long-term outcomes. We're talking 95% 5-year survival in low-risk people.
But it's a major operation.
It is. Opening the chest, stopping the heart, it's a big deal.
But then the game completely changed with TAVI, transcatheter aortic valve implantation.
TAVI was a revolution. It's minimally invasive, usually done through an artery in the groin. In the U.S., TAVI procedures actually overtook surgical ones back in 2016.
And it's now an option for pretty much everyone, regardless of their surgical risk.
That's right. For lower-risk patients, the big trials show that over 4 or 5 years, the TAVI valves perform just as well as surgical ones, with really good clinical outcomes.
And when you have SAVR, You face that crucial decision: mechanical or biological valve.
The classic dilemma. Mechanical valves last a lifetime but require lifelong anticoagulation with warfarin, which carries a big bleeding risk.
And the bioprostheses, the tissue valves.
They don't require anticoagulation, which is a huge plus, especially for older patients, but they can wear out. They face primary valve failure in about 10 to 20% of cases by the 15-year mark. For patients over 65, a bioprosthetic valve, whether TAVI or surgical, is usually favored because its lifespan is better matched to the patient's. It's a careful balance of immediate risk versus that long-term durability question.
So what are the big advantages of TAVI over SAVR?
The biggest strength is in the immediate recovery. Compared to surgery, TAVI results in fewer periprocedural deaths, lower risks of stroke, major bleeding, and new AFib.
And for the patient, a much shorter hospital stay.
Dramatically shorter, and a much faster return to normal life. That's a huge selling point, especially for frail, older adults.
But SAVR still has some advantages, right, in terms of avoiding certain complications?
It does. With TAVI, the rates of needing a permanent pacemaker are notably higher. Also, small leaks around the new valve or clotting on the new valve leaflets tend to be lower with SAVR.
So for anyone who isn't clearly low risk, this decision has to be made by a team.
Absolutely. The heart team. It's a multidisciplinary group: interventional cardiology, cardiac surgery, imaging, geriatrics. They weigh all the factors together.
To wrap up this section, let's summarize the factors that push the heart team toward SAVR versus KBI. When is SAVR the favored choice?
SAVR is favored for younger patients, under 65. It's mandatory if they have a bicuspid valve and also need their aorta repaired. It's also preferred if they need coronary bypass grafting at the same time or if they simply want a mechanical valve.
And TAVI is favored when?
TAVI is the standard for older patients, over 75 or 80, and for those with significant frailty. It's the default for standard calcific AS in intermediate and high-risk patients. The benefits of avoiding a sternotomy and having a faster recovery are just overwhelming in that group.
And finally, the unfortunate category of palliation. When is intervention just not appropriate?
The heart team has to recognize when intervention becomes futile. Palliative care is favored for patients with a very limited life expectancy. Severe non-cardiac conditions like end-stage lung or liver disease, severe dementia, or frailty that is unlikely to improve. If the projected life expectancy after TBI is less than a year, the focus has to shift to quality of life.